Welcome back to the Clinical Athlete Podcast. This is episode 4. The Clinical Athlete Podcast is brought to you by Clinical Athlete, a network of healthcare providers who specialize in the management of athletes. Find your nearest Clinical Athlete provider at clinicalathlete.com. Don't forget about the Clinical Athlete Forum, where clinicians, students, and coaches network, discuss, and share ideas and resources related to sports med, rehab, and performance. And to join the forum or be listed on the Clinical Athlete directory, details and applications can be found at clinicalathlete.com. This podcast in particular can be found on the website, clinicalathlete.com, YouTube, iTunes, where we appreciate nice reviews. Everybody's seems to be super nice, and the podcast seems to be helpful for like 10 people. So if you like it, shoot us a review on iTunes. My name is Quinn Hennick, and I'm a doctor of physical therapy in Orange County, California. And I'm joined by Michael Ray. Mike, how are you?
Doing well, Quinn. How are you?
Man, I'm doing well. Tell the people about yourself.
I'm a chiropractor in Harrisonburg, Virginia. I own a clinic called Shenandoah Valley Performance Clinic, and then co-own a CrossFit gym as well that's attached to the clinic.
And we're also joined by Derek Miles. Derek, what's up, man?
How's it going, Quinn?
It's going well. Tell the people who you are and what you do.
That's an entire podcast in and of itself. Who am I? I am a physical therapist in Sunnyvale, California for Stanford Children's Health.
Ooh, fancy.
All in the name.
You think you're better than us?
For other reasons than that.
That's fair. And lastly, we'll announce some upcoming Clinical Athlete courses and events. We have the 2-day Clinical Athlete weightlifting certification, where we break down and build back up the snatch and the clean and jerk for coaches and clinicians in Brooklyn, New York this weekend, September 23rd, in which this podcast will probably be out after the course, but, just in case. And then Sherwood, Oregon on November 4th, La Crosse, Wisconsin on November 18th. That one is approved by the Wisconsin Physical Therapy Association for CEUs. And then the 1-day Scientific Principles of Sports Rehab, which Michael and Derek co-teach this weekend. Again, if this thing comes out in time this weekend, you guys are going to Virginia. Mike's staying in Virginia. Derek's going to head over there. Falls Church on the 23rd of September, Richmond, Virginia on the 24th of September, so back-to-back days. And then the next week, on September 30th to October 1st, we have a 2-day SPOSR course in Harwood Heights, Illinois, which is a western suburb of Chicago. So you guys will be doing your same 1-day lecture on pain and chronic versus acute pain and tendinopathies, muscle strains, and post-ops, and all the great things when we talk about sports rehab. And then on day 2 will be a lab, where you guys run through progressions of various loading strategies and physical rehab techniques. So that'll be an awesome course. That'll be the first 2-day SPOSR. So we're excited to see how that goes. And then we've got a movement seminar in Springfield, Massachusetts on October 15th. That's a 1-day lecture and lab for coaches and clinicians. And then I'm running a little workshop in Southern California, which I didn't even put the date in front of me. I think it's October 21st or something like that. It's on the Clinical Athlete website. All these events are on the Clinical Athlete website, and that's a workshop for the squat and the deadlift. All right. So today we are going to talk about pain. And this is the only episode that we're ever going to talk about pain. This is the pain episode. No other subject is going to relate to this one. This is it. Mike, brings me to a thought here. Didn't you recently write a blog on the subject of pain?
Yeah, I did on Derek and I's website, The Logic of Rehab. So wrote a brief synopsis on how we can approach pain treatment in the clinical world.
What's the name of that? What's the name of the blog, the title?
Pain Science, Guiding the Path.
And I will say it's not that brief. It's not that bad either, though. First of all, it's a great blog. You do a good job of kind of running through the history, which is, I think, is kind of what we're going to go through today, is the history and defining terms, and then bringing it to clinical relevance. But we've got a few papers to to talk about here, one of which is, the title of which is Updating the Definition of Pain by Amanda, it's a commentary by Amanda Williams and Kenneth Craig, and that's in the journal, not the Journal of Pain, it's the International Association for the Study of Pain, released in 2016. And I want to backtrack a little bit because, Mike, in your blog, you talk about the history of just kind of the study of pain. Can you talk a little bit about that, how you write in your blog, even, in years like the 16th, 17th century, how the word pain came to be and how people first started to study it?
Yeah. So overall, like a brief history lesson in it, the original thought process was very from a dualistic type thinking, where the mind is very separate from the body, and they looked at that pain was more of a consequence of direct tissue damage to an area. And I actually talk about Descartes in the blog, but basically stating that if, say, a foot got too close to an open fire, it would open pores in the foot, and then a single tube would run from the foot to the brain and would release spirits straight up to the brain, and then that would cause pain, and it would be like a 1-to-1 ratio of the amount of tissue damage done in the foot to the intensity of pain that you felt. So it's very kind of simplistic definition of tissue damage equals pain, and it was this 1-to-1 ratio of intensity levels.
And how does that relate to where we are now, or even maybe before this first article that we're going to talk about, because the title of which is an update on the definition of pain? Where were we before that? How has pain science kind of evolved from this 1-to-1 ratio of body tissue damage to pain perception?
Yeah, so as we kind of like progress through from that definition, there was a model that came out called the biopsychomotor model that added a couple things to our previous thought process of how we define pain. And that was much more of the idea of realizing that pain's not just this solely internal experience where there are no outside influences that make up a person's experience of pain. And they added in communicative behavior, pain-based behaviors, as well as protective behaviors with pain. And so it started taking into account, like, there's a social experience and a cultural aspect of pain that can kind of shape, A, how you experience pain, and then B, what are your responses to that pain that you experience. And that gets into a lot more, like, and I'm sure we'll talk about this later, but like how our jobs as clinicians are the social aspect of the pain experience.
Yeah, I think that's the big thing here. And then in the updating the definition of pain by Williams and Craig, they're taking the definition from 1994, in which it read an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So, like you said, there seemed to have been an evolution of from 1-to-1, and here you had this definition from the mid-90s where we're putting emotion in there now, an unpleasant sensory and emotional experience. And so it's not just damage, it's an experience that we have, but still could be associated with tissue damage. But the updated, or the definition that Williams and Craig are proposing, is similar but has a couple additions, which it reads: pain is a distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components. And going through this paper, they talk about why they added things like cognitive and social components. We talk about the biopsychosocial, model of pain. Seems to be where we're moving with this thing. But the biggest thing, it seems, the biggest difference is that pain is an experience that we have that can have many factors kind of play on that experience. Derek, can you talk a little bit about, in your clinical practice, how a patient's experience can affect how they're perceiving pain? It could be somebody coming in, or two people coming in with the same injury, but vastly different perceptions.
Well, everyone's experience is always going to be unique to them. And that's part of the reason why two patients with the exact same thing present so differently. And it is multifactorial, and we as clinicians, one of our big jobs is setting those expectations and helping guide them through the experience of what they're having. And you look at it, pain is a distressing experience. Well, if it's distressing in and of itself, part of our job is to mitigate that stress if we're going to talk about pain management. So it's an entirely different experience if you are constantly worried about where you're going to go, but reassurance, reframing, and looking at the different components from the sensory, emotional, cognitive, and social side of it is really what lets us layer in to be the most effective. And the definition itself does a very good job of pointing out that it is multifactorial. We always like to distill things down to one or two, but even at four, we're just kind of scratching the surface, because layered within each one of these is different components as well.
Does that affect your subjective interview? Is that where you're gaining this information? Is the subjective interview getting an idea of the patient's psyche, their perception of not just their pain perception, but also their belief about the injury, their expectation for recovery, if they have any fear? Are you gaining that information in the subjective interview?
I think interview may even be not the most or the best word to use for it. It may be that subjective dialogue, because interview, it implies I'm trying to garner a lot of information out of it. But if I want to be part of the process, then I want to have a dialogue with the patient where I'm going to gain that information, because then I'm going to get a little bit better feel out of the emotional and social components out of it. There's the one study that talks about how long it takes a physician to interject when a patient is talking. It shows that it's a very short span of time, but if you can prolong that and let the patient actually talk and explain what's going on, around that 2-minute mark is where you really start getting the crux of the story. And I think with an interview, and even how we're taught as clinicians, interview is correct, because it's always what question are we going to ask next? What question are we going to ask next? Where does it take us down our algorithm? But sometimes we get so focused on getting to the end of our algorithm that we miss the story being presented in front of us that would be present if we approached it as a dialogue.
Right, the whole learn how to listen thing, except when you get a patient who doesn't stop talking for like half an hour until you interject. And then maybe you're steering the ship a little bit. Mike, does that definition affect first of all, I guess I'll ask, what do you like about the updated definition versus the old one from the mid-90s?
It's multifactorial, like Derek was talking about, so just kind of broadened our understanding of it, gave us a little more perspective on what exactly are we treating, and I think it just allows us to kind of approach it a little bit differently than previously. I still like the inclusion of actual or potential tissue damage, which is what we'll definitely talk about down the road when we're trying to differentiate between acute versus chronic pain and how to deal with those issues. But it just kind of takes into account the entire person, their sensory experiences of the world around them, and how those can be molded and shaped over time, their emotional response to pain, which could be cultural and socially learned, cognitively, which is where they're experiencing the pain. And it doesn't, again, necessarily mean that they're having any damage to an area, but then also the social underpinnings as well that go with pain. It's a developed language, and there's actually been studies that look at what point in a child's developmental age do they actually start developing the word pain, which, if I recall correctly, is like age 3 to 4. But before that, they have words like hurt and ow and things that would make sense if they're actually experiencing tissue damage. But pain is much more complex than that, and it tends to take time to develop.
Yeah, I like Derek, what you said with the dialogue thing, and I try to get, part of my intake form is trying to understand the patient's reference point or frame of the situation, no matter what the injury is. I'm asking the questions because I need the information of when it started, what I'm seeing mostly athletes, what was your training like leading up to when you start to perceive the pain, but also questions like, what are your thoughts as to what's going on? If you've had other treatment in the past, did it help with the situation? I don't want to say did it help with the pain. I don't say that. I said, did it help? And I let them tell me what help means, and then I say, if yes or no, please explain why. So if it didn't help, and maybe help was decreasing their pain, or maybe it was increasing their function, if they feel like it didn't help, well, why do they feel that way? Because it doesn't. I have no idea what they got in the past, and it gives me an idea of where their psyche is. What are their expectations towards therapy, coming to see me? Are they already negative about the experience of physical rehab, coming to see me because of past experiences, or what they've read on the internet, or their family members having bad experiences, or their experiences really, really good, and they're very, positive and upbeat, and they think this thing is going to go away. They kind of explain those things. So I think just getting as much information about their beliefs and expectations of their own situation, and then how they feel I or the clinician can help with that before they even come in the doors is really, really helpful, because it kind of gives me a one up on, the kind of conversations that we're going to have. And going on, if there's anything more that you guys want to say about this definition, but I kind of want to go into not necessarily the anatomy of pain, but differentiating between nociception and pain perception, because they're not exactly the same thing. And I think this is where we've come from the tissue 1 + 1 tissue damage equals pain, where now it's, we have nociceptors. Our brain is interpreting nociception. One possible output is the perception of pain. Mike, can you talk a little bit more about that? Because there's some papers here explaining, and you talked about it in your blog, a top-down versus a bottom-up influence on pain.
Yeah, so with top-down versus bottom-up processing is kind of how we would look at it. There's been a couple of papers, and not a couple, this has kind of been a reoccurring theme for quite some time in the pain science field. But two articles that we have is the Hawk 2015 paper, and then the commentary on that by Nicolardi from 2016. Both are excellent papers. I will say they're pretty complex to jump into, and they can be a bit daunting if you're not familiar with like EEG readings and like gamma waves and stuff like that. But that would be a good paper to look at, like where they're testing out top-down versus bottom-up processing for pain interpretations for pain. And then there's another good article that I think explains a little bit easier for people that might be able to understand a little bit better, by Lagrange, which is Cognitive Aspects of Nociception and Pain, Bridging Neurophysiology with Cognitive Psychology. And they tend to go through the top-down versus bottom-up definitions and then give a good review of or both of those differing factors with pain interpretation. But in essence, the way we kind of look at this is if you had an acute pain-based issue that was immediate trauma to an area, that's going to be more of a bottom-up kind of approach. And so you could have nociceptors, which pick up various types of stimuli like thermal and chemical, and then it's going to send that information up to the brain, and then that information can be interpreted as painful, and how it gets determined as pain is dependent on a lot of things, like what is the threat value of what's happening to you, or is it a novel situation that you've never experienced before? Like all of these can cause pain interpretation to occur from nociception. So we say that an acute issue is typically stimulus driven, it's intensity dependent, and you usually have an unintentional or reflexive action to, say, the tissue damage. So a good example of this would be like you go to touch a pan on the stove and you didn't realize how hot it was, and you burn your hand, you instantly kind of like let go of that pan. On the flip side of that, we have kind of chronic pain that we look at. And usually with this is much more of a top-down approach to talking about pain science. And that basically says that pain interpretation, for whatever reason, is getting interpreted into the brain, and it's based on a lot of factors like your perception of the issue. It has much more to do with about things like fear avoidance and catastrophizing and your previous experiences with various tasks. So we say it can be task specific. And then those tasks, based on if they previously caused you issues, they could reproduce your interpretation as being pain. So we say this is much more perceptually based versus stimulus based, like bottom up. Either one can have the ability to have pain interpretation, but you're much more likely to have warranted pain interpretation for an acute pain-based issue versus a chronic, where it's very unlikely there's tissue damage going on to an area, and for whatever reason, the brain's interpreting something as painful. Hopefully, I've somewhat adequately explained that.
Yeah, no, that makes perfect sense. But so we're all kind of in agreement that pain, regardless of if it's acute, chronic, pain is a subjective experience. Pain is a perceptual output. So, but what you're saying is with the bottom up, in a more acute situation, our pain is more consistent with an injury. So with actual tissue injury, tissue damage, whatever, nociception is, in that case, is more likely to be one of the main drivers to the output of pain, potentially.
Yeah, and I mean, there's always going to be exceptions to the rules, right? But I would say if we were to have the kind of the broad strokes coverage of this, we wanted to dichotomize out acute pain versus chronic. Acute has a much greater likelihood to be relatable to direct tissue damage, and it would be kind of towards that older definition we talked about at the beginning with the card. Like, you had direct tissue damage, you felt pain, and the bigger issue here is pain in this sense is protective. It's a protective measure to ensure that you maintain your life or limb and functionality of that area that's getting damaged. But there's always going to be exceptions to that rule. I mean, there's going to be anecdotal cases where we hear about soldiers in battle that are having pretty traumatic injuries, and they keep going through battle without stopping until they get to a certain point. So it becomes much more of, we'll definitely have to jump into this at some point, but attention is where we kind of can boil this down to. And if there's a goal that's more important enough to you to override your pain sensation or your pain experience, then you absolutely could override it.
Derek, is that consistent also with your understanding and experience with acute situations being a little bit more consistent in their pain pattern versus chronic?
I still think there's some variability to it, and especially depending on how we're really going to get into the definition of acute itself. But I think you've certainly seen the movement over the past 10, 15 years to where we started seeing a lot more studies looking at base rates and looking at what we consider, or what we'd like to consider, problematic issues in the asymptomatic population, and starting to see that things that we used to see as abnormal are now normal. And some of it gets into kind of the history on the other side of it. We've seen the evolution of pain, but we've also seen the evolution of the structuralist approach, with going from Williams flexion for back pain, Williams flexion being facet, and then McKenzie related to extension. And just, we always like to find something that we want to put our narrative on. And there's a lot of papers that really display that we favor an organic diagnosis, because trying to discuss pain in the subjective automatically gets into some gray area out of this. And with all of that, it also is a knock against a lot of what we see in society and social media now, setting the expectation on these nebulous concepts of what is causing your pain, whether it be an adhesion or your big toe doesn't extend enough. It's all this. When you set the bar, we all see the pharmaceutical commercial. It's like, are you tired? Do you sometimes feel anxious? Well, you now have cancer and you need whatever. But we kind of do the same, or if we don't kind of, we do the same thing when we set patient expectations to say, well, do you have low back pain? Then it's probably, your right leg isn't as strong as your left leg. And that's not the case. There is no corollary out of that. And driving that kind of narrative all of a sudden has people wanting to go like isokinetic test their leg when they don't really need to along the way. And it's bullshit and it's shitty practice if we really get down to it. And we need to be able to think through the situation in a logical manner and be able to discuss the experience with our patient and say, this could contribute a little bit, but it's likely not the driving factor behind everything.
Right. I think it's still, well, and you see the pendulum swing too. The structuralist approach, your disc is equal to your pain, your torn meniscus in your knee is why you have knee pain. But then you see it swing the other way as well, where structure doesn't matter doesn't matter at all. But we can kind of, like you mentioned, our base rates for things like lumbar disc herniations, maybe FAI, tendinopathies, these things, where maybe there's some evidence to say that those quote unquote pathologies may predispose the area to be sensitized in certain populations, or maybe your workload to that area is maybe decreased. You can't withstand the amount of volume and force through that area repeatedly without taking some type of break, or you get sensitized or something like that. So it's hard to find those, it's hard to find a middle ground, I guess.
Well, here's the thing, everyone, and I think they're correct in doing so, knocks the Cartesian model for saying it's all in your head. But is that not the same as saying it's all in your spine? I mean, you are your head, you are your facet joint. It's still you. It's just where do you want to place the emphasis? And if we want to treat the person or treat the patient as a person, we need to realize they're not their facet joint. They're not their brain. They are whoever they are, and we need to help them get back to the best version of that we can.
Mike, you got anything to add on that?
I think all those are great points. I mean, the biggest issue I think we run into as clinicians is we try to attach titles like pain drivers to things, and we're like, oh, this is why you're experiencing pain. And I think the more research that comes out on like what Derek was saying with base rate occurrences in asymptomatic populations, like it's becoming very, very difficult to be like, this is why you have pain. And I find that it's a pretty slippery slope to start to try traveling down that road, because that's where we lead ourselves into false narratives like, oh, it's because you have a myofascial trigger point, or we think you have adhesions, or we think you have whatever, I think that makes it where there's a lot of false narratives that lead patients down bad paths. And then years go by down the road where they're still buying into those false narratives. So we've really created a long-term damage to them.
So the big thing, I guess, is mitigating, adding to the negative expectations and belief on the psychosocial aspect of things. We can't control the experiences that they already have coming into the room, but we can try to reshape those narratives and maybe bring their pain back to the whole. The pain is a evolutionary trait. It's a protection mechanism. It's a threat appraisal. It's there for a reason. Generally, if I take a hammer and bust you in the kneecap, generally it's going to hurt, but it's probably going to hurt. Especially it'll hurt if you see me do it and you're a little scared to begin with. Well, like I had a kid, this is a really weird example. I haven't done this in the clinic, but I had a kid who I was treating for a broken leg, compound fracture of his tibia, and he told me that he didn't feel a thing until people around him started freaking out because his leg looked so grotesque, and then he looked down at his leg, and then it was the worst pain he had ever felt in his life. And so that's, again, one of those situations where maybe the shock overrides even the evolutionary trait of threat appraisal, so it's still, even in that acute instance, the acute and acute scenario, it's still modulated by our experience. That's just interesting.
Well, I think it's attentional awareness as well, right? Like he hadn't drawn somatic awareness to the area until you like physically look down at it. And that's very much what we see in pain research right now, is it boils down to attentional focus.
I mean, you think about like the Spartan races and all those, races that people do these days, where a part of the course is getting shocked. I don't think I've heard one case where any of those people develop chronic pain afterwards. And you're going and getting hit with however many volts, but your attention is, hey, this is fun, I'm going to finish the race. So the entire perspective on it is different. Like, I think you can make the argument if you go out and train really hard, you're going to experience some type of discomfort out of it, but it's not a distressing experience because you're like, oh, this is fun. I finished my WOD today.
Right. It's kind of like, and the first thing that went through my mind when Quinn was using the example of hitting your knee with a hammer, I was like, well, it really depends on what you're into. And I mean that to say, like, if that's something you're into, if you have the belief system in place that it's acceptable amounts of quote unquote, damage to the area of pain, then it's unlikely that you're going to have a negative experience with it.
Well, and it's not pain unless it's negative, right? Based on the definition.
Exactly.
Do you guys? Let's go into the more of the acute versus chronic deal here. Where's the cutoff point? When does something become chronic? Because it all starts as acute, right? Would you say that everybody who walks in the door, their situation began at some point, and you can call that instance or that inflection point as their acute stage?
Yes, to a point. I think there's some research out there looking at chronic pain occurrences in youth, and that kind of, I think, could muddy that water a little bit. But overall, I would argue, yes, that acute pain becomes chronic pain, and our difficulty that they're having currently in the research world is figuring out, well, what causes that transition from acute to chronic. And we're definitely like learning more things as we go on. But the biggest way the research currently dichotomizes it out is typically on two parameters. One would be chronicity of pain, and even the International Association for the Study of Pain, and you can go to their website, they talk about this. They say that it basically overall looks at pain that's lasted greater than 3 months up to possibly 6 months, depending on what source you're going to. But usually we say after 12 weeks that if it's and still continue on, then it's called chronic pain at that point. And then the other one would be an identifiable mechanism of injury that's directly correlated to the injury. Example, an athlete could have, what we viewed as a perfectly functional knee before sport. They went out, played a soccer game, they had an acute contact injury, and they tore their ACL. And that is a direct MOI, right? Because the thought process is they didn't have a torn ACL before going onto the field.
Is it still chronic if they keep exacerbating their once acute issue, or do you keep calling it acute? Like if they don't give it 12 weeks and lay off of it appropriately, or workload, does it start to get like they've kept the acute? Because what if they keep the inflammation up? What if it's actually swollen and then they keep pounding it and it re-swells up and at that 12-week mark? Or is it still chronic just because it's been going on for that long?
Yeah, I think that's a gray area for the field currently, but it would be called chronic if it lasted past that time frame, and it would become much more at that point specific to the injury that we're discussing. So, what are we dealing with? What's the current diagnosis? I think the bigger issue when it comes to stuff like that is if we're trying to diagnose something with chronic recurrent pain, because we know the chronicity of pain, as it lasts longer and longer, it tends to follow a regression to a mean. So you piss it off, it spikes up, it goes back down on its own. You piss it off, it spikes up. So it's still following a standard regression to the mean with pain.
So here would be my case scenario that I'd be interested to hear the counter argument on. If you have the athlete who has just your general backache, and it goes on for a few weeks, and then finally they have a moment where they have an exacerbation and it's stopping them from lifting. You call that acute or chronic?
How
when
long?
that inflection, let's say 2 months.
It depends on if they've experienced it previously. I mean, I think if it were a completely new injury, I would have a greater likelihood to be like, this is an acute issue. But if it's something where they're telling me in the narrative while I'm speaking with them that I've experienced the same issue multiple times throughout my life. And usually, like, we've all had those patients, especially when it's low back pain. It's like, I've been dealing with this for 10 years. I throw my back out once or twice a year. It goes away. It does it again. So if it were just like, I've never experienced this before and it happened 8 weeks ago, I would be much more likely to be like, oh, this is probably, a strain or something like that.
But,
so it'd be acute.
I think this is a good point in that it's not a dichotomy. There is a spectrum on it. And
Sure.
It's much dirtier than that stuff we were taught in high school, where it's like, or in high school, in our practice or in our clinical training, where it's like acute, subacute, chronic. It's like, there's a lot of layers to this. And, I think, I know I definitely had the test where they asked the question, what stage is this patient in? And you're expected to multiple choice it, whereas you're probably better off like short answering it and doing the good old, we need more information.
Yeah, and I think like the bigger picture here is that pain's just fucking complicated, and we don't have it all figured out by any means, but we're learning some things that if we're trying to decide, is this an acute pain-based issue or chronic, there's some things we should pay attention to, like fear avoidance of movement with kinesiophobia, catastrophizing, stuff like that. And I think Quinn made a great point when he was like, I asked them what their beliefs are about their pain, because there's a lot of misinformation out there that kind of tease a patient up, in my opinion, to help them progress towards chronic pain issues. So we want to assess their beliefs in order to re-educate.
Well, especially with back pain, the example that you gave, Derek, I mean, you already you said it, it's multifactorial, but to Mike's point, if that's something that's happened in the past, what is the usual cycle? Because if it's, if it usually doesn't go away, or if he has an exacerbation and it hasn't, those last for another month, then now we're past that, acute phase. And so it's like, what are the histories of those exacerbations? But also, did he go onto Dr. Google and read about it? That could affect things. And it's hard to also equate it to tissue damage with things like low back pain. Because that's one of the cutoffs is like acute. We tend to see more tissue damage. We get into that 12-week range, then we would assume that any tissue damage that was present would have healed by then. But with the lower back, it's so hard to tell. If they come in with an MRI with a herniated disc, it could have been there for God knows long. I'm not sure they can look at an image and see the chronicity of an injury like that, where you come in with an ankle sprain, and based on the mechanism of injury, when it happened, and just the looks of it from the other side, if it's blown up like a grapefruit still, it's way easier. But back pain is just so complex. And if you're not getting any symptoms, peripherally, then it's like, doesn't even matter at that point.
And I think it's much easier, like you were saying, looking at the ankle sprains. If I look at something visually and I can see edema, obvious signs of bruising, abnormalities to the area that are very obvious, and we're dealing with an acute injury. But the problem is a lot of people present with pain experiences and there's no observable signs of anything. And then we already know the issue of being like, well, let's get an image on this. If there are really no red flags that are present for us to be worried about, then we shouldn't jump down that imaging rabbit hole. Otherwise, we're going to be running into issues with, trying to classify a chronic pain patient in a biomedical model, which we can definitely get into that either now or later, but there's a lot of issues with jumping down that rabbit hole.
Well, Derek, answer your own hypothetical situation, and what do you typically do, or do you even worry about it? I mean, in a situation like that with no red flags.
Well, so that's one of the big things that you always have to ask yourself as a clinician is, how is this going to affect my treatment? And I don't think at any point I've ever had a real cognitive moment where I'm like, this is acute or this is chronic. I'm like, this is Jim or Bob, or whoever it is, and this is what I need to do to fix it. So if it doesn't really affect my methodology in how it's, or even more so, we get so driven on the diagnosis that we often forego the prognosis. And acute or chronic in this instance isn't really going to affect my prognosis for it. I know we have some ways with which to mitigate this. And, if there is some more, and this doesn't really do the timeline, this has to go back to your belief side of it. If there are some beliefs that need addressed, that it's always X, Y, or Z that causes this, well, then we need to talk about X, Y, and Z. And it's not so much that it's acute or chronic, it's what do we need to do about it.
Yeah. But wouldn't that affect prognosis to an extent if it's if it's something that's the first time they felt it, it happened, let's say back pain. I felt it on one rep at a 95% pull, and it's the first time I've ever had back pain in my life. It happened last week, versus the other side where I feel I have these random low back pain exacerbations and I've had them for the past 10 years. With the acute situation, you could say, listen, you have the choice to do nothing, and this thing is going to go away on its own and you'll probably just be just fine. But if you is it realistic to say that to the person who's had exacerbations for the past 10 years? Oh, this will be the last one, just leave it alone. Because that's what they've been doing.
That's different, though, because you said, the way you said it right there is it's going to go away on its own. And by the way you did it, it does go away. And a lot of times I'll say to patients, I could put glitter on this and it's going to feel better, or this is going to get better on its own. A lot of my job is to reduce the risk of a future exacerbation.
Well, yeah. Go ahead, Mike.
I think this is where we need to assess it, honestly, if we're wanting to decide whether it's acute versus chronic, because there's some things that are very concerning with a chronic pain patient, like learned helplessness, which is, we could be like, even with the chronic pain patient, yes, we know regression to the mean exists. With both cases, this is probably going to heal. It's probably going to go away. You could say the same thing to a chronic pain patient. The issue is they're going to keep experiencing it because there's certain things going on that need to be addressed with their belief systems, like pain is external to me and I have no control over it. Therefore, I am a victim of my own pain. Those are learned helplessness things that we need to assess in order to alter our narratives accordingly to help the person. So I very much agree, the acute pain-based issue is going to physiologically heal and should clear up on its own, whereas the chronic pain issue is going to keep most likely reoccurring because nothing's being addressed that needs to be.
Well, and that's why I may have different conversation. With the chronic case, I may say, listen, the reality here is that you may have other exacerbations. The difference between how we're going to move forward is the way that you're going to attack the situation, and then the way that you are going to, your narrative. A lot of times they think that there's something wrong with them. They're broken, they're scared. They go back to the doc every time. He gives them a shot and tells them not to do anything for a month. And I say that's going to be the difference. And the hope, because if their goal is pain, it's very difficult. So I say, with these exacerbations, it would be great if it happened with less frequency, the time that it happens, the duration that it lasts is shorter, the intensity of the flare up is less. Like all these things are within the scope of our goals, absolutely. But the biggest thing is that you are going to you're going to keep moving and keep training, and you're not going to lose your function in the midst of a flare up. But I'm not gonna.
Yeah.
It's just a different conversation than if it's the very first time. I sent people.
Yeah.
Right.
Yeah, no, I totally agree. Like if it's an acute issue, like what Derek was with his example, if it didn't have a previous history of it, most likely would classify it as that. And if we had a direct identifiable MOI. But yeah, an acute issue, my conversation is, hey, this is going to get better. Let's not stress about this. Let's see what we can work on while this area is healing and getting better. Whereas with a chronic pain patient, it's much more of a talk about let's start accepting pain and not try to deny it, and then accept that it's in our control to deal with it. So it's just two very different conversations, in my opinion, that I would have with the person.
Derek, what are you thinking?
I don't know, to be honest. I feel like even with the acute, if you look at a lot of it, you still need to address that, because it's one thing now in your people that are low anxiety and you're run of the mill, a lot of them aren't even going to seek your care in the first place. And you think about it, like a lot of us, whenever we're in the gym and one of our friends gets hurt, we're just like, yeah, you're gonna be fine, whatever, and you just kind of walk it off. But if that person came into your clinic, you're probably going to be a little bit more thorough if they were some person that you never met before. And I still feel that those beliefs need assessed in the acute state, just because acute becomes chronic. So I want to make sure that I've at least discussed that and tried to head it off at the pass to decrease the likelihood of it going there.
No, yeah, I did.
Yeah.
Not to say that we ignore the people that come in the door that are acute, but more so, I'm going to have the conversation can be more. We can expect certain things with an acute situation. In this time, you should be feeling pretty good. If your baseline pain or your pain at rest, you no longer have pain at rest, and you can move unloaded. We can start loading, and we can just progress that way. My point was more with the patient with chronic pain. I'm going to be having a conversation, like Mike said, more so learn how to accept pain, rather than having this is, you're going to be fine at this point, boom, 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 because it's just not, we're well past that.
I think the bigger difference, too, that we've kind of overlooked as far as if it's truly an acute issue, there's a high likelihood that they physically can't do something, even if we wanted them to. Whereas if it's a chronic pain patient, it's the belief that they can't do something, not that there's any actual tissue issue that's preventing them from doing something.
To a point.
Does that make sense? Yeah, I mean, it's going to be task specific with a chronic pain-based patient. If we go back to the low back pain example, every time I pick something up off the ground, I experience low back pain. They're setting their own expectation that if they do a particular task, it's going to be the outcome of pain. So they're automatically having a fear avoidance to it. And then with that, if they're catastrophizing about the pain as well, it's going to perpetuate their somatic awareness to it and their attention to it. Because that's what it comes down to. With acute, the attention is much more like, yeah, you got pain because you fucked yourself up. That's going to get better, and you're going to notice it less and less as time goes on. Whereas with the chronic pain patient, it's this constant attentional focus to it, and they ruminate over it, and they have hypervigilance to it. And those are things that we have to address with our narrative. And I'm not saying you wouldn't do that with the acute. I'm just saying you're much more likely to need to do it repeatedly with your chronic. Obviously, it's individualistic.
And so it's back to what Derek said as far as it not... Derek, you said it doesn't affect the prognosis. Do you mean it doesn't affect the prognosis as in the end game? Or it doesn't affect the length?
The end game, I mean, if it is a chronic, chances are our prognosis is going to be a little bit more extrapolated out of it. But in the same token, if we're seeing the acute through and what's going on, then we still may be, a few weeks out or however long it takes us. But with the chronic pain, I think where we can get into this a little bit deeper is it starts becoming part of the person's identity and it starts being reinforced with some behaviors. And everything we know about changing behaviors, there is time with that. And I think a lot of times we like to look at pain as we should be able to fix it really fast. Or you look at all these studies where we can have these short-term effects that everybody touts. But even with acute or chronic, most of the time where we really should focus is on our long-term outcomes and our long-term changes. So when I say prognosis, it certainly would be a little bit lower of a slope on the chronic side of it, but where our focus is ultimately is on the end game and not right now anyway. If that makes sense.
Yeah, I think the point seems to be that education and reshaping beliefs and narratives, if need be, is going to be a part of the game, acute versus chronic. Maybe more of a drawn out thing with the chronic issue, and the narrative may be, first, don't be afraid of your pain, whereas maybe with the acute phase, the pain is a more consistent protection mechanism. Like, yeah, you sprained your ankle and it's blown up like a grapefruit and it hurts when you jump up and down on it. We're going to respect that a little bit because that's there for a reason, versus somebody now take that same patient and, they moved away from you and saw somebody else who mind fucked them or something. I don't know, sprained his ankle a bunch of times and now he's got chronic ankle instability. Fast forward 5 years later, the tissues are fully healed, but that ankle is just achy and he's scared to cut and jump. And, we may say, and this is a conversation maybe later on with a paper we're going to talk about, but the discomfort that you feel when you jump up and down, different type of pain that you felt when things were acute, but now we may actually have to work into that a little bit and be okay with that scenario, push through that perception a little bit rather than the acute phase when we use it to help us, back off.
I think one of the biggest educational points with the chronic pain issue is that there's a low probability and low likelihood this has anything to do with tissue damage. And once you can remove that fear that the person has this belief in place that they're hurting themselves, and that's usually what you see is like they don't want to do something because they think they're going to hurt themselves, and the pain is signaling hurt. And now we have enough pain science research to say, no, pain does not equal hurt, especially when we're looking at chronic pain-based issues. So it's just a new understanding of how to view pain, and it's not so simple as tissue damage, therefore you get pain. You're looking at me weird. Does that make sense?
Which I think would be a perfect segue from the rehabilitation side into the next paper where we talk about the systematic review of should exercises be painful in the management of chronic musculoskeletal pain by Smith et al. And Mike, since you're the pain guy on this one, we call him the pain guy mostly because he's a pain in our ass. But
I'm all right with that.
And it's chronic. It is chronic. So, Mike, you want to go ahead and take us into this article?
Yeah. Give me just 1 second while I pull this up.
Derek, that was a really good intro, man. You're hired.
Yeah. I think you should take Quinn's job from him. We're going to leave that part in, too. But so this was actually sent in to by our one listener on the podcast and asked if we would take a look at this and then talk about it. Did you already say the title, Derek?
Yes.
I tune you out, so it's difficult what I miss. So they're kind of looking at, like, should we be exercising our chronic pain patients into pain with therapeutic exercise and rehab? And this kind of gets at what I was saying is that this belief system's in place that pain equals hurt and that you shouldn't do something if it hurts. But with chronic pain, we know it has a low likelihood of actually being related to tissue damage, so you can reassure them this is going to be okay. They're going to have some discomfort with this, but that's all right. I think where we get into a gray area is very much like how much pain is enough. And I don't think this paper really figures that out. And I don't know that we're ever going to figure that out because it's a subjective experience.
Well, and maybe depends on the tissue or injury at hand as well. We've talked about in the last episode with tendinopathy. It's you pick a point. I don't know of a 5 out of 10 or whatever it is, but it seems like it just kind of depends on the situation. In terms of this paper, it's not that exercising into pain was necessarily better in the long term. In fact, there was no difference. But maybe,
right.
And so is the conclusion more so it's not necessarily a bad thing to feel discomfort during exercise.
Yeah, well, it was more of there was a short-term benefit, a small statistical benefit that translated over for them to exercise into pain. And what that tells me is that most likely perpetuated their ability to accept the pain. And that's why it didn't translate to any long-term outcomes. Is short-term, it was just kind of re-educating them on, hey, this is okay. And a lot of people, especially like when they're going through rehab, and I know how all of us rehab with our athletes and patients is it's going to be mostly like a training, but they may not have ever actually like worked a muscle, so to speak, and they're thinking that that's equated to pain and they shouldn't be doing something because it's causing them injury. So it's just kind of resetting that belief system. It's always going to come back to that. It's setting expectations, altering beliefs about how they feel and think about pain.
Yeah, but you can't look at this paper and say that why it worked. It's just a systematic review saying that it doesn't. It need not be a barrier. So
Right.
this is one of those. We can't be guilty of trying to frame a narrative we want to hear either. It just says that therapeutic exercise into pain doesn't need to be a barrier, and I think that in and of itself, this paper is as much for about the clinician as the patient, because a lot of times the dogma is you don't want to take your patients into pain, and you look at the whole charge of do no harm, and we automatically have associated pain with harm for a long time, and we're starting to kind of move away from that some. And I think papers like this start giving a little bit more reprieve to the clinician as much as anyone, as much as the patient, for where we're going to go out of it. And then you start looking at some of the systematic reviews like we've had for NeoA and increasing function and decreasing pain, and seeing that we need specific strength gains out of it in order to see these effects. And then we realize we're going to have to work into some discomfort. We're going to have to work into pain, but it's on us to, once again, not make it a distressing experience and make it part of the experience to get it where we need to go with our patients.
Yeah, and I think and I know Derek's heard me say this before as we've been presenting Sponsor to people a couple of times, is like the biggest issue I have with chronic pain is, to your credit, Derek, we have no idea why it's effective with exercise. There's a couple of thought processes out there, but really with chronic pain, we could do damn near anything and it's going to mitigate pain and it's going to be analgesic. So I'm not even a proponent of being like, oh, we need to exercise this person, or we need to, a lot of people would say you need to dry needle them, or you need to tape them, or whatever other bullshit that's popular currently on social media. When it comes down to it, it really has nothing to do with the tissue, which we've been saying the whole time. It's much more to be about the person's belief about pain in that tissue.
But to circle back, once again, to go anti-Cartesian for a second, it's not the tissue, it's still the person.
Right.
And it's not
Totally
your spine,
agree.
it's not your head, it's the person out of it. And I think that's something we need to get past as rehabilitation specialists, is to get off this boat of saying it is this minutia. It is, your one part of your brain is firing on an fMRI, even though the highest correlation we have is your subjective experience. It's your left innominate is rotated. Horse shit, it's not rotated, but it's still your left innominate. It is you. It's predicated on that. And driving this narrative of trying to segmentalize or compartmentalize everybody out, how can you ever get a whole person whole again if you're constantly focused on one small component of it?
Yeah, and I mean, Cohen did a paper in 2011 on this called The Stigmatization of Your Patient. I mean, it's exactly that, is if you try to single it and distill it down to a single thing, you are taking away the person's identity. You're stigmatizing them. You're giving them a scarlet letter. And now you're no longer hearing the whole person. You can't empathize with them because you would be trying to empathize with some dumbass diagnosis that doesn't correlate to anything. So we're very much on the same page.
Low likelihood of correlating to anything.
There you go. Low likelihood. Thanks.
Still with us, Quinn?
I am. There's just a lot here. You talk about the structural things, like you have weakness here, and that's why you have pain. Your hips are rotated, that's why you have pain. That doesn't hold up at the lowest level as what we understand with pain. We don't have pain receptors. Your brain, your consciousness is your pain receptor. Your experience is your pain receptor. So what you had said, Derek, with the rotated innominate, that's a gross misunderstanding of the pain process of the perceptual process. It just doesn't make any sense. There's as many people with if you measured them with some non-reliable orthopedic testing that seem like they're quote unquote even, and they can have the same exact pain perception or worse. It goes back to your base rates with pathology. So that doesn't even matter to me. It's just so off the wall. It's just, we have to have a conversation way before you're talking about hips being rotated. We have to have the conversation about just ground level understanding of pain science. But to exercising into pain, especially with chronic pain, I want to dive into that a little bit, because with athletes, we're working mostly with athletes. I have a hard time when I get a family member of an athlete. I have, it happens every couple months. I'll get a person who's a non-athlete, and I define athletes based on their goals. If their goal is something athletic, whether or not they are any good at it, or because most people aren't. Most people are mediocre athletes, right? Let's be honest. Most of the athletes that could walk in your door aren't going anywhere, but their goals are athletic in nature, and so I consider them athletes. But sometimes I'll get a family member who will walk in a shirt and tie and slacks, and put his briefcase down, and he's the dad of the athlete that I'm seeing. And I have, it's a much different situation, because for me, quote unquote, treating somebody with chronic pain just means increasing their fitness level to the task, and then we're having conversations about pain. But this person doesn't want to increase, and fitness has nothing to do with their pain. It's like, we might as well not be weak and out of shape while we're trying to have these conversations over time about reshaping narratives. But with somebody who's not an athlete, I have more difficulty, because I can't fall back on, oh, let's just go get strong and in shape. Maybe I can, but they're not going to do it if that's not their goal. And so it does a lot of times just become a conversation, because are we exercising people with chronic pain? We're not. I hope we're not spinning the narrative that this exercise, you're in less pain because of the exercise.
I also hope not.
How are we educating? In that moment when they do an exercise, they say that feels better. What do you guys say? How do you explain that?
It's so, if it's talking amongst clinicians, we're just redirecting attention away from somatic awareness to an area they think should be painful. And that's what it comes down to, is attentional focus. And that's what we consistently see in the research with pain science, is you're just redirecting their attention. And, we could talk about, well, we're also, I think the easiest rationalization for exercise with chronic pain patients is it often is task specific. There's usually kinesiophobia and fear avoidance of movement with catastrophic thinking. So if I can get them to alter their belief that they think they can't do something without pain, and then we put them in a low threat environment and start teaching them they can, then I think that's the best argument we currently have of why you should exercise them.
Does something become chronic? So you have an acute injury, the pain perception is more consistent with the tissue damage. As tissue damage heals, that sensitization
should subside.
That threat appraisal, but then sometimes it doesn't. It's the smoke alarm that just keeps beeping. It just needs recalibrated.
And then we get that transition. Yeah.
So then, central sensitization is this cascade of areas around the area being sensitized. It's not consistent in the brain map. There's not that local, perception to the area. Then it becomes the treatment then becomes, or maybe the treatment then becomes education. Our exercise selection is then just, it's whatever. It's whatever is going to decrease their fear to a pattern that's generally provocative. I mean, I guess I'm trying to differentiate how it's any different than an acute scenario from an exercise standpoint.
Well, acute selection should be based upon what of the area was damaged, what does it need to be able to do, what does the athlete need to be able to do with it, and then how do you appropriately dose in movement and being cognizant of healing parameters, right? Whereas chronic, go ahead, Derek.
I was going to say, would you say it's more the acute side is how we work around the problem, and the chronic is how we work at the problem?
Yeah, exactly. Yeah, I think that's a great way to look at it. Is we got to hit this head on with chronic, whereas with an athlete with an acute injury, we have to be like, well, you fucked that area up. Let's leave that alone for a little bit. Let's do all this other shit while it's healing, and then as we feel comfortable with it, we start dosing in movements to the area that was damaged.
But that specific exercise in an acute scenario is literally re-strengthening the tissues that were damaged.
Depending on the severity of the injury, what was done, was it a surgical case? Was there a lot of atrophy and deconditioning? Were they braced and immobilized afterwards? Like all of those parameters absolutely would take into account how you're dosing in your therapeutic exercise for that area.
I guess my point is with the chronic situation, I think that the common narrative is to say that the exercise program, strengthening, we see, there's some evidence to say that cardio can help with pain in chronic patients. Strength training can help with pain in chronic patients. And then that's the narrative. You're in pain because you're weak, or you're in pain because you're out of shape.
The issue with all of this is driving an external locus of control, right? You're robbing the patient of the belief that they have internal locus of control over pain control. So the slippery slope of utilizing any modality, exercise or otherwise, with a chronic pain patient is you could instill the belief system that it's external to their ability to control it. And that's not the truth.
And part of the reason, so if you look at some of the research, resistance training does seem to have slightly bigger effects out of it. And if I'm going to spitball on this, I would say part of that may have to do with some of establishing that internal locus of control, because when you start resistance training someone, you see gains pretty fast, especially if you're an untrained individual. So you can start establishing, wow, we went from 10 pounds to 20 pounds. That's a 100% improvement. We've doubled your weight. So if that's the case, then there starts getting some of that positive reinforcement, and they start looking at it as, hey, if I'm at 20, why not shoot for 40? I mean, think about how excited all of us get whenever we change that first number on any one of our lifts. It's like party time, or at least pizza and buffet time. And being able to show some of that gains to a patient and then make them see they're the ones doing it, I think is one of the big parts on it along the way.
And so it's not the act, it's not the strength gain, it's not the top end force production, it's the act of getting stronger that has a change, that has an effect on their beliefs, on their confidence, on their expectations. They're able to do more than they ever thought. Like you said, Derek, holy shit, I gained, I put 40 pounds on my deadlift, and I never thought I would lift more than 20 pounds in my life. That's what the doctor said. It's not the 40 pounds on the deadlift and making the tissues more resilient, or like changing the fiber alignment to make them more stronger at the local level. It was the process that helped to recalibrate.
Well, it also instills some confidence, because one of the other components of this is that whole challenge versus threat thing. And the stronger you get, you start getting a little bit of that. You look at some things like if your max deadlift is 100 pounds and you have to pick up something that weighs 70 pounds 10 times, you may be a little concerned about it. If your max deadlift is 600 pounds and you have to pick up something that weighs 70 pounds 10 times, you're like, whatever, it is what it is. And I think on a daily basis, that outcome gets challenged more than what we see with some of our aerobic side of things. And I'm sure a case could be made that, if you get the person who's walking 100 feet and you take them to 200 feet, there may be an aerobic challenge to that. But I would say societally at large, you may be able to frame it a little bit better through the resistance side, and that may be why we see what we see.
And now we're talking. Go, Mike.
I was just going to say, to the point of how exercise is most likely mitigating the development of chronic pain, we have research on this, and there are studies out there that have looked at this and demonstrate that physical activity does tend to mitigate the development of chronic pain. I know there was one by Nagel, I believe, and I'm blanking on the other one. I was going to try to look it up. But there is research out there that looks at that. And like what Derek said, is it probably has nothing to do with the exercise. It's that the person had the internal locus of control and self-efficacy to take care of themselves and went out and did the exercise.
But now that I'm thinking about it real quick, it may have a little bit to do with it, because Mike, think about the Teixeira article that talks about skeletal muscle loading and regeneration, and actually showed that skeletal muscle loading actually has a direct positive effect on your ability to heal. So, it may contribute to it. Now, once again, it's a percentages game, and we suck at thinking in terms of probability. And, this could contribute 3% to it. But if you get 3% here, 6% here, it adds up instead of just trying to get 100% with one modality or one narrative or, one whatever.
Well, the reason
there's actually.
Go ahead, Mike.
Sorry, Quinn.
That's all good.
There's actually, so I just found the paper, oddly enough, and the title of it is "How Does Physical Activity Modulate Pain?" and it's by Law. It was published in Pain Journal in 2017, March of this year. So that would be an article worth checking out on that topic.
Well, and there's the isometrics, creating short-term analgesia and tendinopathies and these types of things. The reason I keep coming back to this, Derek, the example that you said, if you have to lift, if your best deadlift is 90 pounds and you have to lift 120 times, well, now we're talking, injury risk reduction, but just in the moment, the reason I keep coming back to exercise, the specific exercise, not necessarily relating, is because I get the question all the time, or like I'm sure you guys do, of just like, oh, it hurts. Like they'll point to the side of their back. Oh, it hurts over here. Well, what do I do? What is this? What do I do when it hurts over here? And then the next person will say, well, mine hurts, right in the middle. What do I do then? Because it's like completely different because it's in a spot that's 4 centimeters over. Or like, oh, it's a little higher. It's actually a little higher. And like, it's so weird because last month it was like low, it was right on the SI joint, but now it's like high. So now what do I do?
Stay calm. Yeah. Relax. Pick up some heavy shit. Get plenty of sleep. Drink water. Get laid every now and then.
But is it my
I have now written my opus.
Is it my QL or is it my SI, Derek?
It doesn't fucking matter, and it probably is neither.
Here's what I would say to you, Quinn. You can take a dartboard and put your letters around all 26, throw 2 darts, pick those 2 letters. You have just as high of a probability of guessing right.
But isn't this why doing modalities can even be, especially in an acute scenario? I'm going to needle your shoulder. You've been having shoulder pain for the last 3 years. You've got a trigger point there. I'm going to needle it. So now, not only are you taking somebody whose pain has probably become part of them. One of you guys mentioned that earlier. Like now it's their day to day. They know that if I'm going to go to the gym and do upper body training, I know my shoulder is going to hurt. That's just who I am now. I've got a fucked up shoulder. It's just part of my life. And now you're taking the control completely away from them and putting the onus on some type of intervention that's not even the clinician and the intervention themselves are what's the hope is in those things. And so now you're taking somebody who's already got beliefs that they feel like they don't have the power to control the situation, and you're taking that away from them even further. And so like in an acute scenario with those things, you're potentially maybe setting them up for that road. But at least in that realm, Mother Nature is probably going to take care of it regardless. So you just hope they don't get mind fucked by the modality, and then they can just forget they got it. And like Mother Nature will fix it. The clinician will probably say that it was the whatever it was, because it's really good timing. You healed right around the so. But then in that chronic scenario, it just seems like such a detriment to the patient to give them anything other than something that they could do on their own, regardless of what that is.
I'm still going to argue against modality usage for acute pain-based issues unless we have efficacious evidence demonstrating actual physiological adaptable effects. Now, we can travel down the very fucked up rabbit hole of placebo-like effects and have that discussion. But then again, usually I highly doubt the clinicians coming in the room and saying, this is going to be a placebo I'm going to give you. But if you believe in this placebo strong enough, you're probably going to feel better after we get done with this. Then that may be a little more ethical way of approaching it, but I highly doubt that's actually happening. And then, like you said, with chronic issues, you're just continuing to mind fuck them or perpetuate an unnecessary dependency. And we can see this, like, we talk about our modalities, but we could take this to the physician realm and talk about the opioid epidemic and how we've been trying to treat chronic pain with opioids for a very long time, and now we have this massive addiction issue with it. So we're all fucking this up. This isn't just one group of people.
Mike,
so
okay,
go ahead.
No,
go ahead.
No.
Well, I was going to say, to circle back on what you said a moment ago, Quinn, about making the patient see it as themselves. I think there is some utility in in invoking the royal we, because once again we go back to pain, and there is that social component to it, and part of that really is establishing that therapeutic alliance, but keeping that locus of control on them. I don't want my patients to feel like they're doing it on their own. I want them feeling like they could do it on their own and having the confidence in themselves. But if they don't feel like I'm offering some contribution, then I'm not being effective either.
But ultimately, they're not going to need you, though, right? They're not going to see you.
That's
forever.
the goal. The goal is to put yourself out of business.
They'll be back. Do you use the 1 out of 10? Do you use some type of scale? Do you ask them to rate their pain?
Fucking hate it.
And what does it depend on? Because I'm sure.
What do you mean? What does it depend on? Come on, Quinn. I try my best not to use it that often. And if you look at the stance of moving away from pain as the fifth vital sign, I think there is some good evidence that it doesn't really tell us much. And I think a good entry exam or essay question for PT school would be explain to me the difference between 3 out of 10 pain and 4 out of 10 pain. I would love to see what those papers would come in looking like. And, it's weird that we, and Mike's going to roll his eyes because he's heard me say this so many times, we are so focused on asking about pain over and over and over and over again. If our job is to get you to take your mind off of pain, the last thing I probably want to repeatedly ask you about is your pain. We've all been through that shitty breakup, and all of our friends take us out, and it's not like while they're trying to cheer us up, they're like, man, what do you think your ex is doing right now? Do you think she loves that other guy? What do you think she's doing? Is she at a movie right now? Because you're trying to get their mind off of it. But it's the exact same thing. Because, if you want to talk about what is a distressing experience, I would say that ex walking out on you is pretty high up the ladder on that. Now, definitely, we call it heartbreak for a reason. So there's some pain associated with that. But in the same token, we sit here the whole time and we're like, does it burn? Does it ache? Is it worse, better, or the same now? Are you sure it's not worse? Did we make your pain any worse? And what are we doing when we're going through that entire dance?
And we have research on this because I'm chomping at the bit to toss this in there. But Sullivan did a study in 2006 on this called The Influence of Communication Goals and Physical Demands and Different Dimensions of Pain Behavior. They had people lift various weighted objects off of a table, and they asked them to answer 2 different questions. One was, what is the weight of the object while they're lifting it? And the other is, what is your pain behaviors report with this? How much pain are you having with this movement? And they found pretty easily that if you ask them about a painful experience movement that they're having to deal with, it increase their reporting of pain. But if you refocus their attention on, well, what is the weight of this object you're lifting, their pain scores went down. It really comes down to, if we boil this all the way down, it's attentional focus. And that's where we have the development of expression of pain.
What I like to say is, if your knee hurts and I punch you in the face, then your jaw hurts.
Call that major pain.
So, Mike, you don't use any type of pain scale? Do you quantify pain at all? Or do you
unfortunately, I'm a slave in the insurance model, and so I have to ask those questions. If it's a chronic pain-based issue, I will probably ask at an initial consult, and you will not hear me ask it again.
Sometimes I'll phrase it as on the wonderfully ambiguous 0 to 10 scale, where 0 being no pain, 10 being, oh my God, what's going on? Where are you? And it's trying to take some of the teeth out of the question.
Would you also say that one potential benefit was it can actually clue you in on the psyche of the person if they are one of those people who rate their pain as a 9 out of 10 and they're sitting there chewing gum? Even if you don't ask them ever again, you say, okay, I know what I'm dealing with here.
I would be careful because the thought process is you believe them no matter what. So if someone looks me dead in the eye and isn't showing any emotional, physical, or distress at all, and they say they're a 10 out of 10, my response is going to be the same whether they say they're a 2 out of 10. I hear you. Let's see what we can do about this.
Oh, yeah.
But I'm not going to question it any differently.
No. You're not questioning them, but just in the back of your mind, I'm making assumptions here, but yeah, I was going to say 9 out of 10, maybe more fearful, but maybe not. Who knows?
Well, and that's why we have things like the Start Back tool, to where we can start doing some assessments to where, Tampa scale of kinesiophobia is good, pain catastrophizing scale is good, but if once again, if I don't want to talk to you about your pain, giving you a big scale that has pain and catastrophizing on the top of it may not be our best way to start. But Start Back tool is starting to show some good reliability and validity in picking out those patients that are a little bit more predisposed to being medium and high risk, and the ones, instead of looking at from 0 to 10, it's like, if you're at medium risk, we probably need to spend a little more time discussing some of your thoughts on the situation.
Are you keeping that with your patients with back pain?
Am I keeping it?
Do you have anything else that you use for other cases?
No, I think that's good for the low back side of it. And once again, to circle back to where we started, I think getting efficient at that subjective dialogue ends up giving you a lot of conversation, or a lot of the components of it, and then learning to let your patient talk. I don't think that can be overstated enough. A lot of times we're so hell-bent on telling them what's wrong with them that we fail to see what's right.
Mic drop, man. Did we miss anything? I'm just going through some of the questions that I had mentioned earlier that I like to have people answer before. How long has the issue been going on? Anything like this in the past? Yeah, I just had, if you've had other healthcare in the past, what was the treatment and recommendations? Did those things help? What are your thoughts as to why they did or why they didn't? And then sometimes it'll be like, they'll list off a bunch of modalities and say, well, I just stopped going. I stopped, my insurance ran out, and so I stopped getting that treatment, and that's why my pain came back. And again, and then for me, because right now at this period of time, I don't practice using many of the modalities out there, that when they say that that's kind of like their expectation going in, usually have a conversation with them about that right away, so that they're not caught off guard, or neither one of us are kind of caught off guard if they're expecting something that I'm not going to give them. We can have that conversation up front. That's kind of an aside.
I think a good question to always ask them is, what do you think about your pain, or what are your thoughts about the pain that you're experiencing? I'm totally blanking on the study I read a while back, but actually they did a phone interview and polled people about their chronic low back pain and their thoughts on it. And all of the previous narratives that were given by clinicians or TV shows or advertisements or whatever came out through those phone interviews. And people were saying things like, I'm fearful of my low back pain because I think my back's unstable, and I'm just going to one day pick something up and I'm going to have a fracture, or my disc is going to blow out of my back, or I'm going to not be able to do something. Like, every fear imaginable that was associated with their low back pain really showed through. So asking them, what do you think about this pain, really gives you, it kind of sets you up, to almost knock it out of the park with a home run to re-educate them.
And so I think one of the best things I've heard on the subject that I'm going to attribute to Roderick Henderson, because I think he's the first person I saw say it. As clinicians, a lot of the times we talk about tools in our tool belt, and we want to be Batman out saving the world, but our focus shouldn't be on us being Batman. We should be focused on trying to be Alfred. We want to be the one who's just there to see the situation through and make sure they're not doing anything stupid, or giving them the confidence when they're down. So we shouldn't be thinking of ourselves as the superhero. We're the ones that should be making our patients the superhero, and really trying to facilitate that independence and efficacy out of them.
Yep. Just guiding the path.
What else you guys got?
Pain's fucking complicated. That's about all I've got.
Do you treat pain?
I treat people who may be experiencing pain.
Oh, that was beautiful. God, can we get that crocheted on the pillow?
I already have it.
Okay. Well, that was episode 4 of the Clinical Athlete Podcast. That was a really good topic. Probably we'll come back to that again. Probably every single episode, it's in some capacity, pain will be a topic. But hopefully that was a good start, and we'll probably get a lot more questions about that than we were ever able to give answers to, which is the way it should be. Head over to clinicalathlete.com and check out those events. If you want to learn more about subjects that nobody knows anything about, you'll go to the Scientific Principles of Sports Rehab seminar. And if you want to learn how to snatch and clean and jerk, where we try to ignore all those complicated things and just lift weights, and if you get hurt, well, you signed a waiver, clinical athlete weightlifting certification. And is that it?
That's it.
All right. See you next time.